Hi, everybody. It is actually 6 p.m. in Paris, Nantes, and Hamburg in Germany, 5 p.m. in London, and 11 a.m. actually in noon in New York. Sorry. My name is Mohamad Mohty from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And I would like to extend a very warm welcome to all of you attending this journal club brought to you by the International Academy for Clinical Hematology around the globe and across the hematology field. So today we have a very, I think, important paper which was recently published in the Journal of Clinical Oncology by Dr. Leypoldt and colleague from Germany. And this is about a specific protocol dedicated to the management of high risk cytogenetics, multiple myeloma, or let's call it high risk. And obviously, we will discuss during the discussion the so-called definition of high risk or even ultra high risk multiple myeloma. I'll share a couple of slides with you from this paper. So this is the title of the paper just recently published. And you can see the abstract. It's a phase 2 trial. It's not randomized. It has included both transplant eligible and non-transplant eligible patient. It has also assessed MRD negativity, and the authors tested a very powerful, I would say, combination of quadruplet induction, auto-transplant, strong consolidation, maintenance. And you will see they were able to generate some interesting results. As you can see, the majority of the patients were in the transplant eligible population. 45%, 50% were from the ISS stage 3, but also you had, when it comes to the revised ISS, half of them were in the highest group. You can see the representation of deletion 17p, deletion 414, 42% in the transplant eligible patient. We may wish to discuss this because some colleagues do not consider translocation 414 now these days as a high risk feature. Interestingly, 1/3 of the patient had an amplification of 1q21. Extramedullary disease wasn't overrepresented, but still around 12-19% had bone-related and 9 to 4% soft tissue. Here are the rates of MRD negativity, and I'm sure we're going to discuss this. So if you look carefully, the rate of MRD negativity is quite high, and I'll focus on the transplant-eligible patient. However, and again, this is going to be discussed by the panelists, actually, the rate of sustained MRD negativity at 12 months is going to be lower. So it means in terms of sustainability of MRD, maybe there is some work to do in these patients. And here you can see the progression-free survival curves. Obviously, as I mentioned, this is a single-arm trial, but these curves, at least the shape of these curves and the numbers, look much better than what we used to do to see historically. And in order to discuss this trial and this publication, we're very lucky and honored having the first author, Dr. Lisa Leypoldt from Hamburg. Congratulations, Lisa. And we have also Dr. Cyrille Touzeau from France, who will also, and will brings us into the discussion, actually presented at the last ASH meeting a similar protocol, roughly similar protocol, but we'll discuss the differences from the IFM, namely the IFM 2018-04. So Cyrille, thank you for joining us. Lisa, thank you for joining us, and welcome to this Journal Club. The Journal Club is always interactive, so please don't hesitate to post your questions, your comments, and I'll do my best to share them with the panelists. So as usual, the first question will go to the non-co-author of the paper. So this is for you, Cyrille. I'd like to get your general feeling, impression when you've seen this paper published. I know it has been presented at different meetings as an oral presentation since 2021, I guess the first time I remember. But when you saw the paper and the detailed results, what was your impression?
Thank you, Mohamad. So definitely, I'm very, very impressed by the result from this clinical trial from Lisa and colleagues. You know, I think it's very, very important to address this specific population of difficult to treat patients. And to date, in fact, very few clinical trials in multiple myeloma specifically addressed this difficult to treat population. And this is the job done by Lisa and colleagues. And the results are quite impressive, in fact. So probably we will discuss about the definition of high-risk, but definitely it's high-risk patients. And progression-free survival, MRD negativity rates are very, very impressive. And definitely the quadruplet anti-CD38 KRD in the context of transplant and in patients not eligible to transplant, definitely it's a very, very efficient quadruplet. And we heard during the last ASH meeting, you know, the ISKIA trial, Isatuximab KRD, in all comers, in newly diagnosed myeloma patients, and in the context of transplant, results are very, very excellent. And definitely here we have very good results, PFS results, MRD negativity, safety in this difficult to treat population.
Thank you very much, Cyrille. So you're very, very positive, which is great news. And I agree with you. We are we were historically desperately missing some dedicated trials to high risk. So Lisa, can you please summarize to our audience, because I'm not sure everybody has read the paper, the design of your trial and the rationale behind using such a backbone with Isatuximab, an anti-CD38 monoclonal antibody, a second-generation proteasome inhibitor, namely Carfilzomib, Lenalidomide, Dexamethasone, and the schedule, the design, you know, it is a quite very powerful and extensive, I would say, lengthy treatment.
It is, but first of all, thank you so much, Mohamad, for having me and having us here. I feel very honored that our paper was selected, and I'm very happy to talk about it and discuss it, and felt very honored too by hearing Cyrille talk about it. So coming back to your question, the concept trial is a phase 2 trial, as you mentioned, and it's single arm, technically, although it does have 2 arms. But those 2 treatment arms were according to treatment eligibility. So the treatment arm A was for the transplant eligible patients, and treatment arm B for the transplant non-eligible patients. All of the patients received the quadruplet ISA-KRD, all received 6 cycles of induction, 4 cycles of consolidation, and then for 2 years, ISA-KR maintenance. So this is quite an intensive treatment, as you called it. The difference in treatment was what happened in between the induction and the consolidation, obviously. So the transplant eligible patients underwent transplant. It was possible that they could undergo double transplant if this was open to the investigators, but most patients received just 1 single transplant because the regimen itself was effective enough in the eyes of the investigators. And during this time, the non-transplant eligible patients received 2 additional cycles of ISA-KRD. So they had, you can also call it like 8 cycles of induction and then going into consolidation. So this was how the study is designed. And talking about the design, you have to keep in mind that the study included its first patient back in 2017. So it was designed even before then. And by then, as Cyrille pointed out, there were no other high-risk trials, and those patients were in dire need for better treatment options. And we were looking, or specifically Katja Weisel, the senior author of the trial, looking at what is the best you can get back then. And this was just, you know, the anti-CD38 antibodies were introduced, and ISO did show some early signs of very good clinical activity. And then Carfilzomib, as next generation proteasome inhibitor, had shown its superiority in patients who were also bortezomib refractory. So this was just the more effective regimen. And then together with lenalidomide and dexamethasone, this was sort of illogical, but at this point, very novel combination. And actually also the first study which tried this ISA-KRD regimen. So this is to hopefully give a better frame of how the study came to be, also considering, you know, the time, because myeloma treatment really has elapsed or evolved a lot during the last couple of years.
Thank you very much. And although it has been designed, as you said, 7 years ago, actually, the treatment that you have chosen is very modern. And today, I think it's proving to be highly effective. So let's dig a little bit deeper. So we all speak and mention high-risk multiple myeloma. Maybe, Cyrille, can you give us a reminder about how to define high-risk multiple myeloma? Because I must confess, we always speak about cytogenetics, but if you tell me an elderly patient with kidney insufficiency, frail, I would say this is high risk for treatment, but I don't believe this is what is between the lines when we speak about high risk cytogenetics.
So yes, so you're right, Mohamad. For sure, there is risk linked to the patient, age, comorbidities, etc. But let's focus on multiple myeloma. Historically, we had the ISS score based on the tumor burden, albumin, beta-2, microglobulin. But I would say 10 years ago, cytogenetic became the most important prognostic factor in multiple myeloma. And historical cytogenetic abnormalities were 70p deletion, which is still a major adverse prognostic factor, the T414, the T1416, and the revised ISS combines the ISS, albumin, beta-2 microglobulin, plus LDH, and T414, T1416, and 70p deletion. But I would say since 5 years appeared new chromosome abnormalities that influenced the outcome of patients, and this is chromosome 1 abnormalities, and we know now that 1q gain, 1p deletion is also associated to adverse prognosis. So at the time of LISA trial and at the time of the French IFM trial dedicated to high risk, we defined high risk cytogenetic through T414, 1416, 70p deletion. In LISA trial, I think 1q and 1q abnormalities was also included. And so today, we are, the IMWG group, are discussing a new definition of high risk in multiple myeloma based on cytogenetic, and clearly 1q gain, 1p deletion will be included. And if I can share the last discussion from the group, probably the new definition of high risk will be the presence of 70p deletion, 1q gain if associated to 1p deletion, and T414 and T1416 alone will be not considered as high risk if it is the only cytogenetic abnormalities, but will be considered to be high risk if associated to 1q or 1p deletion. So clearly, the definition of high risk based on cytogenetic is evolving, and we have now the 1q, 1p chromosome 1 that we have to take into account. But behind cytogenetic, probably we have to consider other prognostic factors. And we know that extramedullary disease based on PET-CT at baseline is associated with an independent adverse prognostic, and also, you know, circulating plasma cells, etc. So yes, to define risk in multiple myeloma is not easy. Probably cytogenetic is the most important today. And we know that, you know, there is a dynamic definition of risk, and to achieve MRD negativity is clearly better than to keep a positive MRD disease after induction, for example.
We'll speak about MRD in a few minutes, but just to expand a little bit on the definition, and maybe Lisa, you can answer this. Did you include plasma cell leukemia? Because obviously
Yes.
Plasma cell leukemia is ultra high risk, but also a patient with extramedullary disease. I know the numbers were relatively low in this trial. Was it on purpose or not? Because to be fair, and we need to be fair and also mention that besides this trial, beside Cyrille's trial, the IFM one, there is the Optimum UK9 trial, which has also been published in 2023 in the JCO by Dr. Kaiser and colleagues. And they have used a quintuplet induction, and I think they have included really high-risk patients, a significant proportion of plasma cell leukemia, and so on.
Yes, so we also allowed patients with plasma cell leukemia to enter, and we know that those patients were included. Unfortunately, though, we did not capture the number of circulating tumor cells in the ECRF, so I cannot give you an exact number of how many patients entered. I can just tell you that from our conversations with the individual investigators, we do know that patients with plasma cell leukemia were included. In addition, because, you know, as Cyrille said, the definition of high risk is evolving. I just want to point out at this point in the discussion here that for us it was not just cytogenetics and the abnormalities which were mentioned. And by the way, this was in here only amplification 1q, which was included, but also that these aberrations had to be present in combination with the ISS stage 2 or 3, reflecting the higher tumor burden. So any patient with high-risk cytogenetics but ISS stage 1 could not be included. And we did see that the ISS stages 2 and 3 also play a major role in the second revision of the ISS, the R2 ISS. So they do also reflect a higher tumor burden and high risk. Yeah, so this is how the high risk was defined here. And I think it's always a little difficult, and you have to do it with caution to compare who has the most high-risk patients or not. The definitions were a little different. I do think that all trials did include high-risk patients. The risk itself was defined a little differently. But when you look at the rates of extramedullary disease, because when we were writing the manuscript, for example, I was diving in the literature and looking for other large phase 3 all-comer trials. And I was amazed because most did not even report on the number of extramedullary disease, which must be a sign that there was literally none. And then when you dive deeper, the numbers which we present here are somewhat in the middle, but mostly from what is reported in refractory and relapsed myeloma, where we know the numbers are higher because myeloma evolves. So I think it is probably, well, we did not exclude these patients, obviously, quite the opposite. They were very welcome to be included and were. But yeah, so I think this is something to consider. And it was surprising to me, as I said, that most of the larger phase 3 trials historically did not report an extramedullary disease.
Excellent. Thank you very much. That's very clear. And obviously, we always caution the comparison across trials, but obviously we can discuss the results from different trials to put things into perspective. So before going into the efficacy data, and we have a lot of questions about MRD, for instance, I'd like to handle the safety issue, because we have here a relatively very potent, powerful quadruplet, including Carfilzomib. And we know that Carfilzomib may, at least historically, had a cardiovascular signal. And I was really interested. I never noticed this in the oral presentations you've given in the past, Lisa, that you included in the non-transplant eligible patient up to age 87. So this patient, age 87, I assume, got such a strong quadruplet. And we have also a question from Dr. Salinas Rodriguez about the choice of Isatuximab versus Daratumumab, because we know both are targeting CD38, but maybe, and the mechanism of action are different, so maybe one can provide an advantage versus another. And you, in your trial, Cyrille, you have chosen actually Daratumumab plus KRD instead of Isatuximab. So can you comment, Cyrille, on the safety, and I mean both of you, on the tolerance of such regimen?
Lisa, would you like to start, or?
I can. I was just answering the last question, so I thought you'd go first, but
Okay, so maybe I can start with safety. So when you look at the concept trial and the French trial, I think in transplant eligible patients, no safety issue with KRD plus anti-CD38. In both trials, we had no new safety signal, including cardiac safety. And if we are moving to the ISKIA trial, so 400 or 500 patients as well, no issue with cardiac toxicity in a large number of patients. But we have to keep in mind that this is clinical trial with inclusion-exclusion criteria, and all patients had prior echocardiography to exclude patients with cardiac insufficiency, etc. But to summarize, I think no specific safety issue with KRD plus anti-CD38, with the exception in the French trial. I have to say that we had issue with stem cell collection. And initially in the French trial, stem cell collection was performed after 6 cycles of DARA-KRD induction. And we had a high number of patients with stem cell collection failure. So the study was amended to collect stem cells sooner, after 3 cycles. And at this time, we have no specific issue. But I think we have to keep in mind that with a quadruplet KRD anti-CD38, probably stem cell collection should be performed after 3 or 4 cycles, because maybe it could impair stem cell collection. And if we go back to the past, if you look at stem cell yield after VTD, it was better than VRD, which was better than DARA-VTD, which was better than DARA-VRD, etc. And probably we have now very, very efficient combination, quadruplet combination, but we have to keep in mind that we have to be careful with stem cell collection. We have to use more frequently plerixafor, and especially if you have intent of tandem transplant in those high-risk patients. So to summarize, I think no specific safety concern with DARA-KRD or ISA-KRD, but we have to be careful with stem cell collection.
Excellent.
Thanks so much, Cyrille.
Lisa?
Yeah, I couldn't agree more. It's very important aspect which you summarized, and also with concept, we did not see any new signals for safety-wise. It was just pretty well in line with what was reported with other CD38-based quadruplet regimens. So yes, you have to be careful with infections a little, but all of this can be managed because the hematologic toxicity is really the main toxicity with neutropenia. Interestingly, I must admit, I wasn't aware that you amended your trial. This is actually also what was done in concept very early on. So also in there, the stem cell transplant, the collection for stem cell transplant was done after 6 cycles, and then very early on amended after cycle 3. And ever since, it has been fine in most patients. There are always a few in which it is difficult, but this we also see, apart from clinical trials, and the everyday clinical setting. So overall, this was really manageable.
So when we look over the last 6 months period, it looks like that Isatuximab has become a star because we have this trial. We have the ISKIA trial plenary session at ASH, and we have this famous press release, although we're lacking the data about the IMROS study. So can you maybe clarify the differences between the available anti-CD38 monoclonal antibodies? Because daratumumab is approved, of course, and widely available, and we're celebrating more than 10 years of daratumumab. Isatuximab now is proving its efficacy, and there are other anti-CD38 actually being under investigation from different companies, although they're not approved. Is this the choice of the anti-CD38 is something of great importance, or just take whatever anti-CD38 you would have?
So maybe I'll start first, and then Cyrille, you can add to that. So I think by now there are signs that ISA may be superior in case of gain or amplification 1q, although the mechanism behind it is still not totally clear. But this again may obviously be some reason why ISA may be beneficial in high-risk patients who have, as we have seen, a higher percentage of this high-risk 1q abnormalities. So back when we designed, this was one consideration. Still, you will notice I'm pretty careful with what I say because I myself do not know the full mechanism behind it yet. There have been a few presentations also at ASH highlighting possible mechanism, which was quite interesting. But I think there will be more coming within the next time. And then handling-wise, I mean, by now daratumumab is available in sub-Q. ISA is not. It's still only IV, except for in other clinical trials. But again, as we saw at ASH, I found it very helpful to see that the shortening of the infusion down to only 30 minutes can be safely done in patients who've tolerated it well before. And that's what we actually will be implementing also to, alleviate the time in the hospital for the patients.
Cyrille, what's your opinion?
No, I totally agree with Lisa. So from a practical point of view, in the relapse setting, we have ISA and DARA approved in combination with Dex and Carfilzomib dexamethasone. And so to date, for sure, the sub-Q administration of DARA is very convenient for patients and in institutions. So, and in the frontline setting, to date, we only have access to DARA in combination with a VTD or VRD and with a Lendex in transplant not eligible patients. But with the IMROS results that we will have during ASCO probably and EHA, probably ISA will be approved frontline with VRD in transplant non-eligible patients, and we will be able to use Isatuximab, which is still IV, but we have an ongoing phase 3 trial that is comparing Isatuximab IV versus sub-Q, and it would be great to have access to Isatuximab sub-Q in the future in the daily practice for our patients. We have access to the Isatuximab sub-Q in a lot of clinical trials, and I have to say that ISA sub-Q is very efficient, very convenient, so it would be great to have access to this drug sub-Q in the daily practice.
Thank you very much. Although personally, my opinion is that we always claim that sub-Q is very convenient. It may not be true 100% because when they come to the day hospital, actually, they never spend 5 minutes only as we claim, you need 5 minutes. But nevertheless, and also we've seen at the last ASH meeting, a publication from the French group about the capacity to deliver Isatuximab over 30 minutes. But anyway, that's a debate for another, I would say, discussion. Let's move on now to the efficacy data, Lisa. And let's look into the response in namely MRD. your MRD rate is quite impressive, I would guess, in the transplant-eligible patient. 2/3 of the patient could achieve, but the threshold is 10 - 5, I think, whereas we may wish to get 10 - 6, and I think Cyrille looked into this in his trial, if my memory is correct. But then the issue for me is that at 12 months, which I believe could be the ideal definition of sustained MRD negativity, you have roughly 15–20% of patients who will lose this. And we know from a master trial by Dr. Costa and colleagues that actually many patients may achieve quickly MRD negativity, but actually they will, if you stop treatment, they will relapse very quickly. So how did you handle all of these issues and your take on the MRD negativity rate?
Thanks for the question. I think this is important to discuss. And first, I would like just to clarify. So the 67.7%, which you mentioned, was at a fixed time point that was at the end of consolidation. So at this time point in the intention to treat analysis, 67.7% were MRD negative. If you look at any time throughout the trial, 81.8% were achieved MRD negativity. Now, coming back to the sustained MRD negativity for 12 months or longer, this was now 62.6, if I remember correctly. So yes, it's a little lower, but the problem was the very first time that the assessment of MRD or MRD status was mandatory in the trial was at the end of consolidation. So as it happened, a few patients were just not yet followed up long enough to reach technically 12 months of MRD negativity. So we did lose a few which were censored before. This will obviously be updated with further reports on the trial. But nonetheless, it does show that a few patients, although we are very happy that it's very low number and lower than what we calculated and sort of expected before, a relapse once they make it through the end of consolidation and into maintenance. So where we can still and have to work on most is those patients who relapse early, so within the first 10 months or so of treatment initiation, which can be equally seen in Optimum. And also, I think, Cyrille, in your trial, there are still a few patients which or who, in spite of this intense treatment regimen, are not yet captured full. But I think for most of these high-risk patients, those quadruplet treatments do offer a really great and effective treatment for a long time.
Thank you, Lisa. And just within the same vein, we have a comment from Dr. Hamadi. Cyrille, maybe you can comment on it. How does this MRD rate in the concept trial compare to other trials using similar approaches like the master, and you mentioned Ischia, and there is a Manhattan trial, etc.?
It's a very, very interesting question. It's quite difficult to compare, but you're right. I think we can try to compare with the trial, the US trial, the master trial, sorry. But it's difficult because, as you said, Mohamad, patients who had 2 MRD negative time point quit treatment, stop the treatment. So it's not easy to compare. But if you look at patients with high-risk disease in the master trial, but the definition, was based on at least 2 high-risk abnormalities with DARA-KRD. So after induction, it's quite similar than MRD negativity rates in the French 2804 trial. I can't remember in the concept trial if we had MRD results after induction, Lisa, but
not in the intention to treat analysis, because it was not mandatory at that point. So yes, some patients were tested, but it would not be sort of an unbiased assessment since it was not mandatory. Something we learned we will include in further trials.
But I guess probably MRD negativity results will be very close from one to other trials, concept, French high risk, and the master trial. But I think we cannot compare after that because of, in the master trial, because of the stop of treatment in patients who had at least 2 MRD negative time points. If you look at MRD negativity in the French and German trials, again, it's quite difficult to compare because in the per protocol analysis in patients who receive the tandem transplant in the French trial, MRD negativity rates tend to be superior in comparison with the German trial, but you know, one transplant in most patients transplant eligible in the German trial. So again, design were not similar. And now if we try to compare MRD negativity rates with other large phase 3 trials, Cassiopeia, quadruplet Dara-VTD plus transplant, Perseus, the number of patients with high-risk disease is not very high. And today, I think we have not MRD negativity rate in the specific population of patients with high-risk disease. But I'm sure we will have the results of MRD negativity in high-risk patients in Perseus, maybe in the next international meetings. It will be very interesting to compare those results with the German concept trial and the French one.
Thank you, Cyrille. We have one question here, Lisa. Actually, I'm throwing here 2 questions. One question is, because we were discussing MRD and assuming, for instance, after transplant or at time of consolidation, the patient were still MRD positive. One question is, should we maybe, which you didn't do actually, modify our treatment and incorporate novel other agents? And the other question I noticed in your trial, Lisa, that only like 10% received a second auto. But in contrast to the French trial, where the primary endpoint was almost to get a second transplant, yours was optional according to the practice of each center. So here I'd like to ask both of you about what is the value of double auto in this population? Because these are the trials, but what would be the take-home message for a routine practice today in this population? What would you recommend?
So I think this question is crucial, and there's probably not, you know, like a one-size-fits-all answer, because it also depends on some patient preferences and investigator availability sometimes. But I think currently the data does show the overall benefit of the transplant with regards to progression-free survival, at least one transplant for these high-risk patients. This can also be seen in determination in other trials. It's not so clear about the second transplant, though. And on the other hand, which you also have to consider, especially now with the great development that even these high-risk patients are living longer, is possible long-term consequences of a second transplant. You know, there have been publications by Blood et al., by Diamond et al. And Blood, looking at also detrimental biological effects of a second or transplant in general, and you know, possibly elevating the risk of secondary cancers, which then become important again once the high-risk patients live longer too. So that's why I'm sort of referring to it's probably not one size fits all. Currently, I do think that one transplant is really a standard of care for these high-risk transplant-eligible patients, but we see that these quadruplets are able to induce deep, also MRD negative remissions, also without transplant. And I do know that also here in the US, it's sometimes more, you know, you collect stem cells, but then you hold back with transplant because you measure MRD negativity and you see they're still stably in MRD negativity. So why would you use the good old melphalan? I think this is a field in discussion currently. Or interested to hear what Cyrille thinks about it.
Thank you, Lisa. So our practice, at least in my center, is that if you have deletion 17p, you will get a second auto whenever possible. Cyrille, what is your opinion and your recommendation?
No, it's a very tricky question, and I would say it's quite schizophrenic question, because from one hand, we try to delete transplant from our treatment. You know, we have the CARTITUDE-6 trial, transplant versus cilta-cel. We had a lot of phase 3 trials trying to delete transplant. To date, transplant is superior to not transplant in frontline transplant-eligible patients. And here we are talking about tandem transplant. If we look at phase 3 trials, I think we have 2 phase 3 trials that recently compared single versus double, the EMN02 trial, but in the context of, VCD, VMP induction, so maybe not optimal. And tandem transplant in this trial was superior versus single transplant, especially in high risk, okay. And we also had the stamina trial from our US colleagues. So mostly VRD, for VRD induction for most patients, and then randomization, transplant maintenance, tandem transplant maintenance, and transplant VRD consolidation, followed by maintenance. And the publication in the GCO said that no interest of tandem transplant and no interest of consolidation, in fact. So in all patients, it's difficult to recommend tandem transplants. And in high risk, we missed data, but in the French phase 2 trial dedicated to the high risk, I have to say that PFS with DARA-KRD tandem transplant is very, very good. With a median follow-up of nearly 3 years, we have more than 80% of those high-risk patients that did not relapse so far. So we try to avoid transplant, but I agree with you, Mohamad, and in Nantes, a patient with true high-risk myeloma disease, we try to perform tandem transplant. Is the first one was well tolerated, etc.
Excellent. Thank you very much. And I think it's a wise recommendation. I think these patients, to be realistic, will not make it into the 10th lines of therapy. So either you do your best in the first and maybe second line, and otherwise the war is lost. So we're reaching almost the end of this journal club. I would like to ask you both of you same question: what's next? It looks like quadruplet is a key word now, because we're giving quadruplet now thanks to the Perseus trial for induction prior to auto. Thanks to Cassiopeia, we have Ischia. Now we have the quadruplet induction in the concept trial, in the IFM trial. And of course, auto transplant and a sort of extended heavy consolidation. Let's call it like this, because otherwise we'll have a semantic debate about maintenance, consolidation, etc. So what's next now? What's going to be the next generation of protocols you would love to design in this population, based on the fact that we have other also attractive agents, not only CAR T cells mentioned by Cyrille, but we have bispecific antibodies like teclistamab, elranatamab, talquetamab. We have also the new cell modes, iberdomide, mezigdomide. So it looks like, we have many ingredients to design a new trials. What would be your ideal trial, Lisa?
That's really one of a question we could discuss for another hour or so, but I'll try to be brief. I personally am very much looking forward to the integration of bispecifics also in the high-risk population, because they will add a totally new dimension to it, targeting BCMA mostly, also GPRC50 or others, but mostly BCMA so far, and thereby add another direction by which you target the myeloma cells, and have achieved really impressive results on their own already. And by integrating them, particularly also in the first line, where the immune system is not quite as well disturbed from earlier treatment lines as in those for relapsed and refractory myeloma trials, I do think that they really have the potential to improve the outcome further, especially for those patients who are not yet helped enough by the current quadruplet era, let's call it like that. So that's really one thing. And also the CELMoDs, I think they may potentially add another layer of efficacy.
Wonderful. That sounds reasonable and very ambitious. Cyrille?
I cannot agree more. We would like to incorporate in those quadruplet and transplant protocol the new immunotherapies, and bispecifics is a very attractive combination with quadruplet maybe. And I know that there is a future trial that will test in high-risk patients quintuplet, anti-CD38, proteasome inhibitors, IMiD plus bispecific. So definitely bispecific is attractive. And we heard the results of Redirect 1 study during last HIHA meeting, TEC plus TAL in very advanced patients, including high-risk patients. And it's very, very impressive. It's almost cilta-cell results. And, if you can imagine trials that with maybe a transplant and maybe a consolidation with Tectal, etc. So definitely we have to probably to include bispecific, maybe CAR-Ts in frontline treatment in those high-risk patients.
Thank you, Cyrille. So Lisa, the last word is for you. This is how we conclude. You can say anything you want.
Well, it's well then I would very much like to thank you for your discussion, and also everyone who listened and asked questions, and particularly also at this point Katja Weissel. I mentioned her before. She's the PI and the lead investigator at the concept trial. But really looking further to further discussion on or offline.
Thank you very much, both of you. It was really a fantastic discussion. Again, congratulations, Lisa, for this lovely work. And I think it brings a lot of hope, I think, and perspective to this group of patients with unmet medical need. And I think we will continue to improve. So thank you all for attending. Thank you for sharing your thoughts and questions. As you noticed, I replied sometimes personally to some questions because they were not necessarily within the scope or we didn't have time. But I'm sure if you have other questions, you can reach out to the panelists. So for now on,
definitely.
Thank you so much. And please stay safe and keep well. See you soon.
Thank you.
Bye, everyone. Goodbye.
Bye.
Thank you.